So COVID-19 and wider societal response brought health inequalities into sharp focus, be it globally on maternal mortality risk, where 99% of maternal mortality risk lies in developing countries, with 1 in 16 women affected in Chad, Central Africa, and 1 in 10,000 in Sweden, in Europe. 2 examples close to home, where there is an 18-year age gap in the healthiest areas of Britain to the unhealthiest areas of Britain. We see that enough evidence to show that social determinants and there are a lot of health inequalities that exist. The whole system needs to work together, and that's why we have 3 amazing panelists with us. I would like to welcome Juliet. She is the Deputy Chair of Women's Health Initiative at Women in Data, which is a community of 60,000 women across 85 countries. She focuses on gender inequality, healthcare, and improving data representation for women. Next, I would like to welcome Dr. Lee. He is the CEO and Chief Scientist at Action Against Age-Related Macular Degeneration, a research charity focused on the leading cause of legal blindness and its earliest stages. He has expertise in molecular and structural biology and has implemented successful open-source public-private partnerships for drug discovery. Lastly, I would like to welcome Dr. Melissa. She is the head of research data strategy at Cancer Research UK, where her role is to deliver a strategy that supports cancer research to make the use of big data models and approaches such as data science and AI. Her team works with data custodians, innovators, on people affected with cancer to co-develop solutions to the challenges in the space. The common theme, really, that brings all of us together is that they're all involved in work that goes beyond clinical data to transforming healthcare. So that's my starter question to the panel today. What are the opportunities posed here that clinical data alone would not provide? And if I could start with you, Melissa, since you have the mic with you.
Sure, okay, thank you. So the power of data kind of beyond clinical data and multimodal data. Yeah, so I think in cancer research, we're learning more and more about risk factors associated with cancer, and we are moving more towards, or at least kind of balancing out our portfolio and making sure that we're focusing on developing new treatments for those who have cancer already, but also really driving a focus on early detection and prevention of cancer. And of course, when we're talking about preventing cancer in the healthy public, clinical data is not of so much use because these people don't have cancer yet, and therefore we really must look at other sources of data associated with risk factors. And there are lots of different risk factors and lots of different social determinants of health and cancer risk that we are trying to make the most of in order to answer these really important questions about cancer. So smoking status is one. We know socioeconomic data is another. And in the case of children and young people, for example, I think some of the treatments for cancer in children and young people are really quite toxic. So although they, in many cases, do cure the cancer, it leaves children and young people with life-limiting or health-limiting conditions later on in life. So actually bringing in data such as educational attainment and even employment data for those who are survivors of childhood cancers are really important as well. So I think there's lots of opportunity which we're already taking advantage of, but want to do more in to kind of bring in other data types as we're thinking about preventing, diagnosing and treating cancer.
That's amazing. Lee, would like to hear from you.
Sure, perhaps. Oh, okay, hi. Well, welcome everybody and thank you for coming. Well, frankly, if you go out and talk to some of our 60,000 women in our community, they will say to you, we can't wait to become a clinical stat. And that's what they're doing at the moment. So if you realise that only 1% of health research goes towards women's issues and disorders, that is quite a frightening stat. And if you think globally, there are currently 190 million women suffering with endometriosis and 450 million women suffering with menopause, and yet very little research. And something like endometriosis, the time to actually have a diagnosis is on average 7.5 years. 7.5 years of pain, suffering, perhaps not being able to work, therefore loss of economy. And therefore, we are starting to look at all different data sets, because our community is not just health people, it's commercial people, it's people in all different industries. And we thought, well, we need to get together and see if we can pool, yes, some of the clinicians who are experts, but along with some of our different thinking to try and address some of these problems rather than waiting for our women to become another clinical stat.
That's great. I like always to be the last one, because then they always give me a very good substrate to build on, Paul. I don't have to repeat. But I think I'd like to take the opportunity to think about the word clinical, right? When we talk about clinical, we still think about hospital data, things that we collect in hospital settings. But the ability of linking to other data sources is where we can discover new associations, which first, one of the earliest ones to be proven in medical research is smoking as a cause of cancer, right? So remember, in the late 19th century, smoking was recommended by many doctors as a good expectorant, and so on and so forth. So what we know about clinical is defined by what that field think they know. But it's really looking at the interface we can find those new discoveries. And already we've alluded to lifestyle, and also I've been building on what Juliet said, some of the things like menopause or age-related macular degeneration. And even 20, 30 years ago, losing your memory, that was all part of the aging process. But it should not be. So can we look at other factors that can help us understand what that is? And the final point I'd like to make is, when we think about clinical, what we're saying is things that are already being developed that a medical doctor can diagnose as a disease. Why should we be content with addressing a losing match on the 89th minute of a football match? We should be actually acting way before. Therefore, think about things that might be clinical, but it's not considered as so. For instance, when you go to a dentist, when you go to your optometrist, even though you're healthy, there can be a lot of data there that we can extract and help us drive new discoveries toward prevention and interception of disease as early as possible.
Thanks. As the Times Commission report says, the intention is to move towards being a healthcare service than a sickness service. And we know health inequality is a global issue. Cancer affects everyone, young and old, rich and poor, and presents a tremendous burden on patients and societies. So Melissa, if I could ask you, how can the wider use of data really help address these disparities from the work that you've been doing? Would be great to hear your thoughts.
Yeah, thank you. So there are some great health inequalities in the cancer space. People from more socioeconomically deprived communities have worse cancer outcomes. That is in part to do with the 2.5 times more likely, a greater likelihood of smoking in those communities, which is a risk factor for 15 different types of cancer, not just lung cancer. There are health inequalities across ethnic minorities. People in minority ethnic groups are more likely to have their cancers diagnosed later, which leads to worse outcomes than if they're diagnosed earlier. And there are many examples where the treatments that we have in play for cancer are more effective in men versus women. There are those examples. So there are some, and I could go on and on with the health inequalities. There are lots of examples of that in the cancer space. And I think data has great power to address these health inequalities. So first of all, we need reliable data in order to describe those health inequalities, because the only reason we know any of that I've just said is because we've been able to access the data in order to describe some of these health inequalities. But it's also a big part of the solution. But in order to study health inequalities and address them, understand the causes, and develop solutions around them, Well, there are some real challenges in doing that from a data perspective. So often we find that the data sets that our researchers are using when they're looking to, interrogate health inequalities are just not representative of the cross section of our communities. So we need to, drive up, build trust with these communities, involve and engage them in the research that we're doing, and drive up inclusion in clinical trials and other clinical research. Often we find that even when the research cohorts are diverse, and that hard work of building inclusion into that work has been done, we do find that sometimes that data isn't reflected in the metadata. So we have these data sets that are completely lacking in ethnicity data, for example. And there are various reasons for that, some of which, sound sort of justifiable, but we really need to kind of get on top of that and make sure that we have the right kind of metadata reflected in order to do those studies. So I think for lots of different reasons, data is key to describing these issues and addressing them, but there are various challenges and blockers in doing that, and that's something that we think about a lot in cancer research. We have at Cancer Research UK, and we have various initiatives and interventions in place where we're trying to change kind of data culture in order to lay the groundwork for this really important research, and ultimately for the benefit of patients and the public.
Just in the interest of time, I would also encourage all the audience to think about questions that you want to ask in the end, because we will leave some time for audience engagement as well. And it really, your response tells me that addressing inequality is difficult, but seems like data is trying hard to do that. And that kind of brings me to the role of public sector. So Juliet, if you could really, with the multiple hats that you've had and your experience in executive roles in the private sector, really talk about what role does the private sector have to play in all of this in doing it, and if you can give examples from your work as well. Yeah.
Certainly. So I think the private sector has an enormous role. Most of my executive career was in the private sector, in commercial data sets, retailers and things like that. And more companies are wanting to get involved and try to help with some of the big issues in the world, like health inequalities. So we have been, frankly, inundated with people that want to play part in it. But actually, thinking of our colleagues here at Cancer Research UK, one of the cracking studies that they did recently, well, a year or so ago, working with Boots and Tesco data and Imperial, was looking at shopping behaviour of women who then were diagnosed with ovarian cancer. And they saw significant increases of women taking pain relief and indigestion relief for up to 8 months before they then went and sought help. So this is already being used, and there's some further analysis I know that's going to be taking place in thinking about how do we, this is a prediction, so how do we use this to inform women and help them, educate them on what they should be thinking about. So we're looking at similar shopping pattern data, currently working with NCR and with Boots, and ONS open source data and some health data, and we're looking at patterns of behaviour to give us indications of health issues, and already, I can't spoil it all gets announced in March at the Women in Data flagship conference, but there are some, as you'd imagine, some areas that we are seeing there are shopping patterns that change before women are sort of seeking help for things, particularly women's issues. I mean, I use the example that I'm sure we're going to find with things like perimenopause and menopausal issues, as suddenly women start buying eye drops and antihistamines and pain relief, then they've never had any allergies before. But there's quite some interesting research that's coming through. And I think it's, if you think about lots of large organizations, they have a lot of data. And I think it's asking them to contribute some of this data for good as opposed to for commercial returns. And many of them are very happy to do that, we're finding.
Thank you. I'd just like to add a few more points to what Juliet's mentioned, because it's always this, perhaps in our initial interaction with industry or data controllers, to see whether that should be just all open or all closed, all commercial or all non-commercial. But I do believe there are midway solutions, compromise is the wrong word, but actually a better way of structuring this. For instance, we can think about being able to define an area where data stewardship, for what use the data can be deployed to, as something that could be perhaps outside of the commercial remit. And then another one where innovation comes in on the use of data, where there can be a commercial narrative. Because we all know, as many of the charities, many of us depend on donations. And even in academia, that is not sustainable long term. If we cannot find a way to actually fulfill a healthy ecosystem of data where data safety and use is guaranteed, that is not corruptible by money, and innovation as a separate stream, where we want to see this product developed, I think we have to start opening the discussion between the society, the charities, academia, and the industry. And then final one I'd like to add also to Melissa's point, data inequality. I think there are two components here, very careful. In this community here of data users, be aware of all the data you're using to develop all the algorithms. They come with a lot of bias from the previous decades of data aggregation, which never thought about this. And they will surface, and they will creep into your AI algorithms, and that is bad and detrimental until we start seeing those downsides. For instance, again, taking on a cancer case, right? We know there are some image analysis that you can do with your phone to see whether you might or might not have melanoma. But of course, that is always measuring contrast between the melanoma spot, which is dark, to your background skin. That doesn't work well with people with non-fair skin. And all the algorithms that's been developed were trained on only Caucasian studies. And the second thing is for aggregators. Charities and companies doing data aggregation, build in your equality straight on. Don't do it as an afterthought, right? Consult with the different communities. And once you do this, always communicate with your developers what they're trying to do. So basically your framework.
A slight gear shift. So in the recent Times Health Commission report released actually this week, 64% public said that they would be willing to share their data for research purposes. And if, Lee, I could ask you, like, what do we really need to encourage the non-patient public to be sharing more data? What role and what ideas do you have with regards to that?
Oh, thank you. I think that's a great question, because every time we talk about health data, people, as you already mentioned, think about disease data. I have such disease. So for instance, as Action Against AMD, we are interested in preserving the site, even before we become this disease called age-related macular degeneration. But when I am trying to work on a research strategy by bringing other patient groups to say, let's all agree that we want to preserve eye health, the first question that I have from many of the other disease charities is that, hey, why you from AMD and not me from glaucoma? So whoa. This is not a zero-sum game. If we're preserving health, that should be a mission of all of us together, right? Irrespective of what badge will be. And making the society understand that people say death and tax. I think becoming patients is also another very high certainty that we will become. At the present stage, we're all pre-patients, right? So can we think about that way, that we want to preserve the health before that really hits us? If by looking into this societal narrative that we can get people to say, yes, let's all help each other. So whenever I am ill, come time, there is a solution because the scientists had a head start working on it. Or if my kids have a problem down the line, the scientists already have a head start working on that.
Sounds like a complex business problem. And if I could just ask all the panelists one question and then get to the audience. This all seems like a complex business modeling problem. So what are the regulatory interventions or any interventions from the government that you think could really be a shift, cause a shift in the debate that we're having? What could be that thing? Melissa, if we could start with you.
Oh, well, I was going to pick an intervention that's less to do with governments and regulations. Is that allowed?
Yes, it is.
Because I guess just really wanted to emphasize inclusion in all of this. So, in charities, in government, wherever it is, whichever organisation is taking decisions around policy, kind of in this space, I just think we really need to be driving inclusion and diversity through all of this. We need to have, more diverse research participants. We need to have a more diverse workforce of data scientists who are using this data to answer questions about health inequalities. We need to have more diversity in the upper echelons of, of the organisations who are commissioning research. And just across the board, I think it's so important to be including those voices and representatives of those who are in those groups who are underserved. And that is not to put the onus on those people to, address a problem that they had, no hand in creating in the first place, but to make sure that we are being inclusive and are embracing those who want to come and be a part of the solution. But even just having more diversity across the board, even in cancer research, for example, even when it's not to do with health inequalities, but just to provide that perspective in other areas of cancer research that are aside from health inequalities. So that would be my intervention.
So mine would just be, I don't think we need government involved. I'm not sure that's really helpful, frankly. But I would build on the inclusive point that Melissa's making, which is, as well as thinking of all the different communities, I do worry that health research, you still have all the academics sitting in their lane doing their academic research, and aren't they brilliant at it? But I think what I've learned through the community that we've built is it's different thinking of all sorts of different people in different sectors that will get us to the answers. So I think if you know people that are out there, encourage them to try and join up with different charities and different universities and different organisations and businesses to try and solve some of these problems.
So I really like, what I want to say is really, really just what Melissa and Juliet mentioned. But I think instead of intervention, perhaps incentives for charities to work as the honest broker in the whole process, right? Existing partners, they have had their opportunity, many of them really squandered, but charities are very well positioned. And instead of leaving to perhaps a government intervention into, let's do this top down, I think we should be working with charities to actually get the population and the society to buy into it. It's not, we want your data, you have to give us because you use the NHS. Rather, that the society, us all together, have to say, I want to contribute to the future of my health, or my kids' health. How can I sign up? What can I do to push this forward? And then have the charities, which in theory, many of them are by statute non-profit, that we remove that confounder from the equation and start pushing that agenda forward in the right way possible. Transparently, sorry.
Thank you. I think that's so really sums up that how the whole system really needs to work together if we want to address health inequalities. And just one thing for the audience that I wanted to acknowledge is that the agenda of the conference is very much open, but especially when it comes to healthcare, there's of course data sitting across from shared to closed to highly sensitive data and open data. So it's something to kind of acknowledge as well, which probably merits a discussion in its own right, sometime else, another 30-minute panel. But really wanted the last 5 minutes, probably we can take 2 questions from the audience. We have 2 volunteers already, so that's amazing. I'll just, thank you. This is great.
Thanks a lot. My name's Paul Atherton. I'm a fellow at the Royal Society of Arts, but I'm also a chronic fatigue sufferer. And you may be aware that there is a current project called Decode Me, which is the first ever DNA study into ME/CFS. So my question really is that was driven, as you were saying, not by government. In fact, there is a war between government and ME/CFS sufferers. NICE introduced GET and graded exercise therapy as a therapy or a cure, and CBT, and there was a war that's now won. But I was intrigued, do you find once you've collated the data and assimilated the data that you then hit a barrier with the state or with government in actually moving forward based on that data?
I mean, I think it depends at what stage you're at. I think what we're trying to do, thinking about similar to what you've been doing, is that when we do get some initial insight, we then want to drive that out through some of the bigger organizations, academic institutions who can, if you like, push it further and put some more money behind the research. So I'm hoping we can do it that way and get more support. And hoping that we're not going to, but I'm hearing what you're saying and heeded it. But that would be our plan, is we're trying to move it out into a bigger environment, while we still campaign about it hard, and we do campaign quite hard. So our voice normally gets heard, but it's not easy. I hear you, and good luck.
I might just add a quick addition to that. I think that when at CRUK, I think we've learned that when we are developing kind of major research programs, which we expect to be translational, and so to actually translate the findings into clinical practice, we maybe this is just kind of pointing out the obvious, but we aim to engage NIHR, the National Institutes for Health Research, and NICE and other kind of relevant regulators and other kind of government bodies at the very beginning, even before we've funded and initiated that research, but in the setup phase, so that we have that translation in mind from the off, because often that means that we slightly change the work packages or slightly change the people who we involve from the outset. And I think often what happens, and we're definitely guilty in over the years of kind of trying to address that translation, that kind of implementation gap a little bit too late. So now these days and in recent times, we aim to have to really build that engagement in a really meaningful way from the off, very, very early days.
And then finally, I would like to add that exactly that would be the right approach in my view. But also when you move to new fields, for instance, when we look at the clinical research, we have a very well-established protocol. We know the regulations. They're there for a reason. They're not just because they want to create work. But then when we try to move into, for instance, we're going to start this year a data collection of eye scans. Not the front of the eye, like biometric, but back of the eye, so your retina health. So we are going to aggregate that and try to make that available for research for both for-profit and non-profit, because innovation happens anywhere. We cannot shut the door. But then before we actually launched this, we spent about 3 years navigating. If we went to this next step, what are the regulations in this space? Where are the routes that we can take, which is safe, approved, and acceptable? So we are mapping all of those before even launching it. So I think that will be the answer to perhaps your question. We all have to start thinking about this actively instead of say, let's launch into an effort. When we hit the wall, we figure out. Sometimes it doesn't work.
Thank you for an excellent panel, and I particularly appreciated you highlighting the need for equality and inclusion when it comes to the data sets and considering historically underexplored diseases that affect women, amongst others. So my name is Jen Tridrell, and I'm a PhD candidate at the University of Cambridge, but I also have a background as a human rights lawyer. And I was recently reading about the Blair Institute's proposal that the NHS should establish a new public-private NHS data trust to commercialise and sell access to anonymised NHS records. And the cynic in me is that this is maybe a way to raise money for the NHS. But from your perspective and thinking about openness and trying to improve the efficiency in which we treat various diseases, if you had any particular responses to this proposal.
Yeah, we'll kind of really brief. So thank you so much. I think there's a lot of keywords hidden there that people have not unpacked. The first one is contract. So we can see contract, people immediately think about money. But what if the contract was to say, any farmer that develops something on the back of NHS data gives NHS a free license to use at cost, right? So this is really a different way of just counting beans. And we have to be realistic. Our government is not rich enough to support all the rare diseases research. Our government, even industry, cannot. So why do we think that the money will come out of the sky and enable this? We need to find a solution. So I would look more carefully into that, what that contract says before actually hammering it down or say, yes, let's fly the flag.
Thank you for such an amazing panel, and thank you for the really great engagement in the end. I think addressing inequality is not easy, but the power that data has is definitely in ensuring that we try to leave no one behind, and I hope all of us do not end this conversation and topic here. I think this is, I was discussing with the panelists, this is probably the most non-tech panel of the entire conference, and would just reach out, collaborate. I think that's the essence of the work we're trying to do here, and hope that this conversation continues after this as well. Thank you. Thanks, everyone. Thank you, panelists.